me okay? Awesome. It's a little much to manage 2 screens, but thanks for bearing with me. Today, closing out our fall seminar series for the Center for Pharmacy Practice Innovation, we have our current co-directors, Teresa Salgado and Dave Dixon. They're going to be presenting on the diabetes prevention program, which we've been having here at VCU for a number of months now. So they're going to present kind of 2 sides of it, and I'll let them delve into more about what they'll be talking about. But we are going to have all the questions at the end so that we can get through their 2 parts of their presentation and then do a longer little question period at the end here. So I'm going to just leave it at that so they can get started. And yeah, sound good, guys?
Sounds great. Thanks so much, Madeline. Good afternoon, everybody. Can you hear me okay? Great. All right, so we maneuver on through the slides here. So the claiming credit information is there, and we will definitely show that again at the very end. So you'll make sure to have your opportunity to claim credit. And I'm just going to jump right in. So the first presentation is going to be a survey project that I've been working on, survey of CDC recognized community pharmacies providing the diabetes prevention program. Disclosures for both Dr. Salgado and myself include that we are supported by a CDC grant, and I will mention this again later in my presentation. So objectives for my half of today's seminar. I want to set a foundation and really make sure that everyone has the same kind of working definition of what pre-diabetes actually is, and talk a little bit about the development of the National Diabetes Prevention Program. And of course, summarize a survey research project that characterized CDC recognized community pharmacies that are currently providing NDPP. Okay, so what exactly is pre-diabetes? And the most basic definition is that it's when the blood sugar is higher than normal, but does not meet the criteria to be considered diabetes. There is quite a bit of controversy about the definition of pre-diabetes and whether or not we should actually pay it that much attention. But if you look at the observational data we have, it's pretty clear that individuals with pre-diabetes have an increased risk for cardiovascular disease. And there's actually data suggesting about a 10 to 12% increase in all-cause mortality. So it's definitely a marker of something abnormal, and I think warrants attention. But I think it's important to note that there is controversy about how exactly we should define pre-diabetes. According to the ADA standards of care from a diagnostics perspective, the diagnosis criteria include either an A1C elevated between 5.7 and 6.4%. And you'll note that the cutoff for full-blown diabetes is an A1C of 6.5% or higher. You can also diagnose pre-diabetes using either a fasting blood sugar or an oral glucose tolerance test 2 hours postprandial. So in terms of the prevalence and awareness of pre-diabetes, this is some data from the CDC showing that the prevalence of pre-diabetes is relatively stable. This data only goes up until 2016. If you look at the awareness of diabetes, however, we have significant room for improvement. As not even 15% of those with pre-diabetes are aware that they have the label or condition. So as a result, we have approximately 1 in 3 US adults that meet the criteria for pre-diabetes. This isn't too surprising when you consider that the most significant risk factor for developing pre-diabetes is either being overweight or obese, both of which cumulatively affect about 1 in 2 or 1 in 3, depending on what reference you use. But 1 in 2 or 1 in 3 US adults are either overweight or obese. So the similarity and the prevalence rates there shouldn't be too much of a surprise. Now let's talk a little bit about the Diabetes Prevention Program study. I'm not here to go through all the intricate details of the study, but basically it was a randomized clinical trial where individuals that met the criteria for prediabetes were randomized to either an intensive lifestyle intervention, and I want to emphasize the word intensive, or metformin, 850 milligrams twice daily, plus a sort of more standard education about healthy eating and exercise, or placebo. And there was actually a fourth arm in the original study when it started with trioglitazone, but that agent was found to cause liver toxicity. So very smartly, the investigators decided to discontinue that arm. What I really want you to take note of here is the intensive lifestyle intervention, which included 16 lessons that covered diet, exercise, as well as behavior modification. We all know that getting our patients to improve their diet and exercise, a lot of the underlying kind of issues there that must be addressed are related to the behavior, kind of developing those habits and making more of a permanent lifestyle change than going on a typical crash diet. The courses were taught on a one-on-one basis during the first 24 weeks. They were designed to be flexible, culturally sensitive, and individualized, which is pretty impressive. As you can see, the study was published nearly 20 years ago and started, probably 25 years ago. So a little bit ahead of its time in terms of really being intentional about developing a program that was culturally sensitive and individualized. Subsequent individual sessions were held on a monthly basis, and group sessions with case managers reinforced behavioral change. So again, I'm going to reiterate here, this was an intensive intervention. This was not kind of casual education. And this program extends, approximately a year. The DPP trial went on for about 2.5 to 3 years in total. So what did they find? Somewhat surprisingly at the time, they found that the lifestyle intervention was actually the most effective tool to reduce the incidence of type 2 diabetes. Metformin was also more effective than placebo, but when compared to lifestyle, you can see that metformin fell a little bit short. So to make this a little bit more digestible here, so the incidence of diabetes was nearly 60% lower in the lifestyle intervention group and 31% lower in the metformin group compared to placebo. So again, both interventions were effective, but clearly the intensive lifestyle intervention was the most robust approach. So after this study, one of the big things we always struggle with is how do we implement these interventions in clinical practice? As you can see that the original DPP was published in 2002. After about 8 years, Congress authorized the CDC to establish the National Diabetes Prevention Program. So this was very much based off of the original DPP study. It's a 1-year lifestyle program with basically a 6-month period where participants attend weekly classes. And then in the remaining 6 months, participants participate in monthly classes. In 2016, CMS finalized a rule to expand coverage where individuals who were covered by Medicare could actually participate in the National Diabetes Prevention Program, and providers of NDPP could receive reimbursement. And this started in January of 2018. It's hard to believe that it's been almost 5 years ago, but the CDC awarded grants to 12 states, including Virginia, to build out the NDPP infrastructure with a specific focus on underserved areas. And this is the actual mechanism where Teresa and I both received funding. So what about the role of community pharmacies in supporting the diabetes prevention program? So there are really 3 primary ways, and this comes from a commentary that Teresa, myself, and some others published in Pharmacy Practice. And really pharmacists in community settings can play a huge role, whether it's educating patients and increasing awareness of prediabetes, actual doing the screening, whether it's a hemoglobin A1C test, a point of care test, or fasting glucose, or using the prediabetes risk test that's provided by the CDC and the ADA that's available on the web, and you can also do a printout form. And it really looks at the individual risk factors to see the likelihood of risk that you may have for developing diabetes. And then lastly, really delivering to the diabetes prevention program. So enrolling patients in a pharmacy-led NDPP, or maybe referring to a local NDPP provider. In order to better equip community pharmacists to play a larger role in diabetes prevention, they did put out this resource guide. The link is provided there. It's a really thorough guide to again, really motivate, kind of a call to action, so to speak, to get more pharmacies involved in DPP. Okay, so we've got our first question, and feel free just to drop your answer in the chat. Make sure everybody's paying attention this afternoon. So based on the Diabetes Prevention Program trial, which intervention is most effective at reducing the incidence of type 2 diabetes? Metformin, lifestyle, triglyceridone, or glipizide? Looking for 100% here. Excellent. So indeed, lifestyle was the most effective. Okay, so now we have that foundation of what the diabetes prevention program is. Let's move into this research project. And really at the time, it's been a little over a year ago when we started this, it was really unknown the extent to which community pharmacies were really involved as providers of NDPP. But clearly in terms of, from the CDC perspective, there was a lot of interest in using pharmacies because the uptake of DPP has been generally limited. If you look at the proportion of eligible participants, the number that are actually enrolled is quite small. So the objectives of this study was to characterize CDC recognized community pharmacies offering the diabetes prevention program, and to determine the impact of COVID-19 on program delivery. Because as you can imagine, about a year ago, we were very much in the thick of the pandemic, which continues to drag on, unfortunately. So we figured it would make sense to kind of get an idea of how COVID has impacted their program. This was a cross-sectional survey, a 23-question survey was developed. We tried to keep it as brief as possible, realizing, again, this is during the pandemic, a lot of things going on, community pharmacies continuing to feel the pressure, and playing really a vital role in dealing with issues related to COVID, especially on the immunization front. But we wanted to obtain information on program inception, delivery, recruitment, how they were evaluating their programs, if they were obtaining reimbursement, and then of course the impact of COVID. The survey was pre-tested by expert evaluation from two, certified lifestyle coaches with significant experience providing the National Diabetes Prevention Program. Based on their input, we did make some minor edits to improve clarity. So we obtained a list of all CDC recognized community pharmacies that were offering NDPP through a registry that the CDC provides. It is available online. This was conducted September 19th, 2020. We did exclude programs that had not enrolled at least one cohort. So as I get into more of the methods and we started to actually reach out to these pharmacies, if they didn't pass that kind of screening question, we did not include them because we wanted to include pharmacies with experience of actually enrolling participants and actually delivering the program, not just saying that they were going to deliver the program in the future. Each pharmacy was contacted through telephone using the phone number we were provided in the registry list. We used a standardized script to invite either a primary representative, if at all possible, someone really involved in their NDPP, to complete the survey either over the phone or online using a Google form. I will say that overwhelmingly, most participants use the Google form. A follow-up email was sent or a phone call about 2 weeks later to pharmacies who had not responded in order to increase our response rate. So flow diagram of eligible pharmacies. So of all of the CDC recognized programs of any type, there were 1,754 of those programs. 1,681 were not based at a pharmacy, so we excluded those. Of the remaining 73 programs at community pharmacies, 7 had not enrolled a cohort. 1 was a duplicate entry, and 1, after we contacted them, actually we found out it was not a pharmacy. So we were left with 64 community pharmacies that were eligible. 27 of those responded for a response rate of 42%, which we were quite pleased with, especially given, again, this is very much in the middle of the pandemic. So what did we find? So some basic characteristics of the pharmacies that responded. You can see that the majority of pharmacies that are offering the diabetes prevention program are located in the Southeast and Midwestern United States. This is not probably a huge surprise. If you look at the CDC prevalence maps for overweight and obesity, you'll see that the Southeast and the Midwest typically are ahead of other regions of the country, unfortunately. Overwhelmingly, over 3/4 of pharmacies providing DPP were independent pharmacies. And in terms of CDC recognition status, about 3/4 of pharmacies only had pending status. So to provide some clarification here, a program that gets started essentially can submit an application that has to go through a review process. So if you're at that stage, you're considered to be pending. Once the application is approved and the program has demonstrated that they've been able to retain at least 5 program completers, so participants that have gone through the program, you can achieve preliminary status. And then full status really requires providing data, doing that evaluation component to demonstrate that you are indeed achieving the desired outcomes. And the desired outcome that's mostly emphasized with DPP is % weight loss from baseline. So again, you can see here that only a small number of pharmacies had acquired full recognition status. In terms of program characteristics, so on average, programs have been offering NDPP for about 2.5 years. The majority of programs were offering their classes in person at the pharmacy. However, you can see that about a quarter were providing kind of a hybrid virtual in-person option. Community health center, so kind of a site outside of the pharmacy, which makes a lot of sense. Not all pharmacies would have probably the right space to do group classes. Some programs were offering virtual, and then there were a variety of other options there. As far as individuals involved, no surprise, primarily pharmacists, technicians, but it was nice to see that a lot of pharmacies were involving students and residents, as well as non-pharmacy healthcare professionals, such as nurses and dietitians, and then a smattering of others, even just non-healthcare professional types, maybe community health worker, physical trainers, all kinds of different individuals. Programs had an average of about 2 certified lifestyle coaches. In terms of partners, about half were really not partnering or collaborating with any other entity, but it was nice to see that a little more than a third were collaborating with medical practices, as well as community health centers. Not that much involvement from a health system perspective either, so potentially an area for improvement there. Advertisement was primarily through word of mouth, flyers, and electronic media. Reimbursements. So 3/4 of programs approximately were not making any submissions or claims for reimbursement. So this is unfortunately kind of a consistent theme we see with a lot of pharmacy practice, clinical pharmacy services, where that reimbursement piece is missing. So again, pretty large area for opportunity there. There were a handful that were submitting reimbursement from Medicare. In terms of charging the participants, overwhelmingly most programs were not charging, but you can see that some were. As far as outcome measurement, change in body weight was measured by most, with hemoglobin A1C and physical activity following body weight. In terms of actual outcomes, so you can see that the proportion of participants achieving at least that magical 5% weight loss from baseline, you can see that approximately half of pharmacies were reporting that less than half of those participants were hitting that mark. So that may explain some of the issues or maybe reluctancy to go down the path toward reimbursement, because you really do have to demonstrate that you are meeting the metrics in order to obtain reimbursement for DPP. Impact of COVID. I know this is just a huge shock to everybody, but yes, COVID did impact diabetes prevention program delivery at community pharmacies. You can see that 88% either strongly or somewhat agreed. you can see that only about 2/3 of programs were currently offering NDPP. So about 1/3 of the pharmacies had actually halted their program, obviously related to COVID. At the time of the survey, pharmacies had about one current cohort, a median of one, with a range of 0 to 4. Number of participants, a median of 3 with a range of 0 to 22. So a number of programs, actually still functioning with pretty large classes, but clearly a lot had been impacted here from COVID-19. So where's all this heading? Also back in 2017, the CDC selected the APHA Foundation to implement DPP in pharmacies. This is a project with a collaboration between Kroger and Solera Health to implement DPP with a particular focus on underserved communities. I'm not sure of the status of this. I've not heard anything new. If anyone on the call knows any insider information here, that would be great. Feel free to chime in. But again, I think kind of emphasizing that the CDC recognizes the opportunity here, and they're really investing in community practice as a mechanism to increase access to DPP. All right, our last question. So based on the survey results presented, what is a potential area for improvement for community pharmacies providing NDPP? Decrease involvement of other healthcare professionals, increase the cost to participants to join the program, decrease the number of partners and collaborators, or D, increase opportunities for reimbursement to ensure sustainability. Good job, absolutely D. Okay, conclusion. So a modest number of community pharmacies are recognized NDPP providers, according to the CDC. The majority are located in the Southeastern and Midwestern US, offered by independent pharmacies. Sustainability remains a critical area for improvement. Unsurprisingly, COVID-19 did impact program delivery. And there continues to remain really limited evidence demonstrating that community pharmacies can effectively provide NDPP. So further research is certainly needed from that standpoint. Acknowledgement. So I do want to acknowledge P4 student Rowan Spence, a co-investigator that really did a lot of this work, called all the pharmacies, really did an outstanding job, and was very happy that she received a Best Poster Award from the Ambulatory Care Practice Research Network at the 2021 ACCP Virtual Poster Symposium. And also want to acknowledge co-investigator Evan Sisson. With that, I'm going to hand it off to Dr. Salgado. Thank you.
Hi, everyone. Can you all see my screen and hear me okay? Yes, thank you. All right, so now I'm going to present the results of a qualitative analysis that we're doing with our own cohorts of our DPP programs here at VCU. There we go. So first of all, we don't need no more introductions on what the diabetes prevention program is, but we do need an introduction of the diabetes prevention program at VCU, and then sort of guide you through the impetus for our study, and then our goals, methods, results, and conclusion. So at VCU, we have two main locations where we offer the DPP. One is the VCU Health Hub located in the east end of Richmond, and the other one is VCU Stony Point, which is located in the south side of Richmond. So very different populations being served here, which you will see that can also affect some of the results. So we started offering the diabetes prevention program at VCU in 2019. It's a multidisciplinary collaboration between pharmacy faculty and learners and the VCU Health Dietetic program. So as you can see throughout time, we involved multiple learners, both dietitians and PharmD learners. And in the fall of 2019, Dr. Evan Sisson had the brilliant idea, I think I'm crediting the right person, of training our P1, our incoming cohort, as lifestyle coaches. And so as you can see here, by December 2019, when they finished the fall semester, all of our P1s are certified lifestyle coaches. And so, between 2019 and 2021, we have increase the number of lifestyle coaches by 259. At some point, we when the pandemic hit, we had to transition over from in-person to online classes. And so, so far we've had 6 cohorts, 2 of them virtual, and a total of 81 participants in our VCU DPP program, an average weight loss of 6 pounds at 6 months. So the first half of the program, and then another 6 pounds at 12 months. Well, a total of 6 pounds at 12 months. So we've contributed with these programs to a total of 276 pounds lost. As I was mentioning, one of the adaptations we had to make to the program was to move it to virtual, to online using Zoom. And in January of 2021, from then onwards, we implemented a new adaptation to the program, which was to create personal lifestyle coaches. So our P1 through P3 pharmacy students now serve as lifestyle coaches. They're matched with each of the participants, and they sort of provide midweek support. They provide goal achievement. They promote goal achievement. They increase session attendance. So this was all performed as a means to engage our students with our DPP cohorts, but also to sort of increase this retention of participants in our programs. So as we reflect on the needs of the program, on where we can improve, we decided to obtain feedback directly from the participants. So we wanted to understand how the program was going from their perspectives and to inform future adaptations and improvements. On the other hand, but on the other hand, we wanted to understand, we had low participation from residents in the East End of Richmond in Health Hub, and we sort of wanted to understand what recruitment strategies would make sense in this area, but we wanted them to be participant informed. So we sought their feedback in both recruitment strategies and also retention strategies to increase the time and ensure that they complete the program. It's a year-long program, so it's a huge commitment. So the aims of our study, in summary, are two. One, to explore participants' perceptions of the DPP offered at VCU and to assess the implementation of patient behavior changes in light of the theoretical domains framework. And second, to understand factors that lead to attrition of the program and what recruitment strategies could be used to increase participation. And I have in parentheses among underserved communities, because that was the objective that we started off as. As you will see, it was also hard to engage them in the interviews. So we don't have a lot of representation. So we can't really claim that all the strategies that we will propose are for underserved communities. But I also wanted to point out that as we analyze the data, and I'll get into a little more detail on this when I talk about the data analysis, but these are what I'm going to show you are some preliminary results. This is not finalized. We haven't reached our goal yet. So just as a brief introduction to the theoretical framework being used here, it's the TDF. It's a theoretical framework. It's not a theory. So the goal is not to look at the relationships between the different constructs and the domains. No, it's just a way to provide a theoretical lens through which we can view the cognitive, the affective, the social, and environmental influences on behavior. It was initially developed to assess health professional behavior. It's used, it's from the implementation science literature. And then it was expanded to being used to also studying patient behavior, which is what we're doing in this case. The initial version included 128 constructs sorted into 12 domains, so very hard to operationalize. It's still kind of hard to operationalize with the 2012 version with 84 constructs and 14 domains. It's not going, I'm going to give you a brief, just a brief introduction of the 14 domains, but it's not our goal to identify every single domain in our interviews. We will identify whatever people talk about, and we're not, this is not an exhaustive list that we have to check all of them. It's a framework. It gives us some guidance. We are using it as some guidance to inform our future strategies and to understand how the program is helping our participants implement behavioral changes. So, and because I don't have a lot of time, so the 14 domains, basically, remember, keep in mind that these are things that will help participants implement the lifestyle changes that they learn from the program. So the different domains we have here are knowledge. People need to know that something exists to be able to implement. Knowledge of the DPP program, they need to know. Knowledge of their health condition, knowledge of their risk factors in order to be able to act upon and really want to make those changes. The skills, whether they have the ability to implement those changes. Social, professional role and identity. Basically, it's a coherence, it's a set of behaviors and personal qualities of an individual within a social or work setting. Beliefs about capabilities, pretty similar to the theory of planned behavior, perceived behavioral control domain there. Optimism, the confidence that they can do things and that they will be able to accomplish their objectives. Beliefs about consequences, so what happens if I do the behavior. Reinforcement, any reward system or stimuli that would help them continue to implement those changes. Intentions, so again, very similar to theory of planned behavior and reasoned actions. Goals, so if someone has a goal, I want to lose weight, then it's, if you have a goal, then it's easier to pursue something that it's your goal. Memory, attention, and decision processes. And I'm gonna be very honest here. We were 3 of us coding the interviews, and some of these were really hard to code. We had a lot of debate in reading through them. I think we still have to, give another 1 or 2 passes to make sure that we're implementing things appropriately in our analysis. So basically, memory, attention, and decision processes is the ability to retain the information and then be able to act upon that when you're making a decision. Like if you go to the supermarket and you learned how to read nutrition labels in the program, that you're able to apply that information. You pull it up from your memory and then you can make a decision. Environmental context and resources. Do people have the resources? Are there sidewalks for them to be able to walk and put in some exercise as part of the program? That's a basic one. Social influence is very similar to subjective norm in the theory of planned behavior. Basically, what other individuals, what influence they have in their own behavior. Emotion, and then behavioral regulation, aimed at managing or changing objectively observed or measured actions. So it's a lot, but basically the study design is an exploratory, descriptive, qualitative study. It was conducted between August of 2020 and January of 2021. We included the DPP participants at both locations that had completed the first 6 months of the program, so the weekly sessions. We conducted semi-structured telephone interviews. The interview guide that we used was based on the theoretical domains framework, as I mentioned before, and we recorded and transcribed the interviews. Data saturation, for those of us who may not be familiar with qualitative analysis, data saturation is a theoretical concept, and it means that no new content is being identified from new interviews. So it's the point at which, if you bring in a new subject into your study, no new information is going to be arising from that because the topic has been saturated. You've reached saturation. As I was mentioning, we did not, for some of our objectives, we did not reach saturation. And so in qualitative analysis, the process of data collection and analysis and recruitment is iterative. So you conduct the analysis and that then informs if you need, to go out and collect more data and conduct more interviews, which in our case, we will need that. The interviews were then thematically analyzed using a qualitative software to help organize the data called Atlas. We use deductive analysis where basically we sort of matched, we try to identify within our transcripts the theoretical domains framework domains. And within each domain, then we inductively derived other new themes that arose. So at the end, okay, sorry, just checking the time, and I think we're good. So far we have conducted 12 interviews, 8 at Stony Point Clinic. And mind you, when we started this, there was not a lot of people who had completed the first 6 months of the program. So now we have a larger pool to go and pull participants from. But we were only able to get 4 interviews from the Health Hub. So it's challenging. It's challenging to get people to participate. But this is really what would really help us target and be more strategic when recruiting and when retaining our underserved communities in such programs. So the mean age of our participants was 61. They were all female, and 50% identified as African American. So going back to our aims, the first one was to explore the patient's perceptions of the DPP. The opinions were all very supportive and very positive. They were happy. They really liked their coaches. They learned a lot. They were able to implement the lessons from the program into their daily lives. And we've seen some, from the slide that I presented before, that people were able to lose weight. Despite all this positive feedback, there were some program improvements that were proposed. One of these suggestions was to make the material less basic. It was written at a 3rd grade level, if I'm not mistaken. These materials come from the CDC, so there's not a lot of leeway that we have there. And it's supposed to make it accessible to everyone. So, I understand that for someone who may have some health-related training, the material may seem basic, but it's not under our control. They also suggested more realistic examples, and they focused on the sharing experiences within the group as a means of providing more realistic examples of how people were able to implement such behaviors, focusing on specifics about healthy food and recipes. And they also suggested that in addition to the group sessions, that there would be some one-on-one component, which we have addressed by incorporating our students as their personal coaches. As I mentioned before, halfway through, we had to shift to online delivery of DPP. There were some advantages for sure. Time saved commuting was a big one, more flexibility. Some people had children, and so they were able to attend when they were napping, or if they were just being delivered remotely, and they felt safer, within the COVID environment. In terms of disadvantages, there was less opportunity to interact with the peers, lower engagement from participants when they were online compared to in-person classes. One of the participants was saying how, often the coach would ask questions and there would be like a silence because there's no, there's not that same engagement than when you're in person. Losing people due to technology issues and Zoom fatigue. So I'm giving here an exemplar quote, to illustrate this. It's not like when you're sitting in a classroom and you're chatting with someone that's sitting beside you. I mean, we didn't interact with each other. The interaction was all between the teacher, the facilitator, and those of us attending the class. So the next one, within the same objective one, but more now focusing on the domains from the TDF. In terms of knowledge, there were several women who reported knowing that they were at risk of developing type 2 diabetes, whether it be because there was a family history or because of their weight or because their A1C levels or other labs weren't within the reference range. And so, because diabetes run heavily in my family, and right now I don't have it, but I was kind of frightened of it. And I wanted to get more information on it, what to eat, what to do, so I can keep my numbers down. So this is one of the participants from the Health Hub. And you will see that I have the de-identified participant numbers. When you see HH means that it's Health Hub, SP means Stony Point. And then, some participants knew that they were at risk, and some of them already had some knowledge, but wanted to use the program as a means to build on previous knowledge, namely with regards to the whole plate balancing, what types of exercises to do, how to read nutrition labels, and so on. Just seeing that and thinking back to how I was measuring and eating before I received the cups, it would have been helpful to have had it on set. So basically, we provide at some point in the program some measuring cups so that people can see the portions that they may eat, or it's recommended that they eat. And so that was a really eye-opening experience for some of our participants. In terms of intention, one of the other domains from the TDF, just experiencing the benefits of the program for themselves was, a trigger to them intending to continue to implement those changes because they were experiencing those benefits firsthand, wanting to learn more about being healthy, staying committed to the program, and then joining the class due to a health concern to help implement lifestyle changes. So the program really, just by being into the program, it sort of, if before they had the intention to join, when they were in the program, they had the intention to implement, everything that they were learning about. So the main goals of participants that, at the top of the list was weight loss. Other participants also mentioned preventing progression to diabetes, adopting a healthier lifestyle, and developing a mindset of accountability through the program with the coaches and with the other participants, really making sure that they would follow through with their decision and their intention to change their lifestyle habits. In terms of beliefs about capabilities, first of all, self-motivation and empowerment, how DPP motivated me, empowered me, just that I knew I was going to learn something and I knew I was going to help. It was going to help. I knew it was going to let me get to my goal. So really this self-motivation that I can do this, I can get to my goals. Overcoming setbacks was another one. So sometimes the beliefs about capabilities could be, directed towards a positive, and some would be directed towards the negative, in the sense that I was doing so well, but now because something happened, I can't do it as well. And in this case, someone was really excited about how things were going, but then the last 2 months, because I think she had an accident or something, haven't been able to walk, which was her primary method of exercise. And so just, and then, after a sentence like this, what follows is more of the supportive nature of the group and how they develop bonds and they support each other, and then in overcoming setbacks. And that's what you're going to see here. So the social influences, basically, for some people, the support from family and friends and relatives to participate, like the spouse is being very supportive of them participating in the program, their friends, joining with friends as well. But then the program itself, both in terms of the participant, but also in terms of the coaches. So sharing advice with other individuals going through the program, forming these relationships, sharing the setbacks and experiences, and this nurturing environment and these group dynamics really helped them implement and follow through with what they were learning through the program. And then the coaches also played a critical role in motivating them, in forming relationships, in motivating them to implement those lifestyle changes, and then reporting back to the group. In terms of skills acquired during the program, participants reported learning new ways to exercise, things that they would do as the group class, and they would do it at home, and becoming more aware of the importance of exercising. They also learned about reading the nutrition labels and measuring the food portions. And so there were a lot of remarks about going to the supermarket, reading the label and making decisions based on that. And that was I think it was quite exciting, and the participants were very, very excited to have that knowledge as well. You know, as part of this learning experience, then they were able to develop new food and activity behaviors and changing attitudes towards lifestyle changes. And then they also talked about some stress management skills that I believe it's covered in the program. I thought it was interesting that they recognized that they also learned some stress management skills. Finally, reinforcement is the rewards component of the program. We provided some stretch bands that were really appreciated by the individuals who participated, and you know, and they could use those stretch bands to sort of replicate the exercises that they did in class. And then the measuring cups, they really thought it was an eye-opening, and this was also presented before. So in terms of our aim two, focusing on the recruitment and retainment strategies, the participants suggested that diversifying recruitment sites such as churches, gyms, senior communities, and then would be, you know, a good way to go. And then advertising the program through social media and flyers, personalized letters, or TV ads could be, you know, a strategy to increase recruitment. And then providing incentives to participants, inviting individuals to trial the program, and using current participants as ambassadors. For strategies to improve retention, weekly check-ins from coaches via email, text, or phone, which we are currently doing, group sharing of recipes and their experiences. Someone mentioned meetings outside of the program for outdoor activities as a means to even promote even further the group dynamics. And then some other incentives like exercise tools or food discounts were also mentioned. Finally, adopting a hybrid format. I guess when we were in person, people would always mention, well, if it's online, it's easier. But then once we moved to online, well, there's that component of in person that we're missing. And so I think they settled on the hybrid format where some sessions would be delivered online, and then there would be some other ones where you would meet for the exercise component and the group dynamics. This is not part of our results from the qualitative study, but I just wanted to show you what it looks like for our cohorts 3, 4, and 5. Our cohort 3 had 13 participants. It was in person, and the average number of sessions attended was 6.6 for a 25% retention rate. And then the cohorts 4 and 5, which were virtual, you see that there's like a higher number of sessions attended, and the retention is also much higher. So I think this tells us that, you know, providing more flexibility and the adaptation of moving to online really helped participants. And so it's really just continuing to listen to them and to meet the needs and meet them where they are. So in conclusion, overall, the participants had very positive perceptions of our DPP program at VCU. They recommended some improvements, some of which we have already implemented. They reported gaining multiple skills and being able to apply them in real life, which I think it's a huge victory for us. And then several recruitment and retention strategies have been proposed. It's important to keep in mind that the fidelity of the program as designed should be kept while incorporating these changes to the program. Yeah, I think the hybrid in-person online modality can be explored, making sure that we keep the fidelity of the program. So as self-assessment questions, the first one, why was the TDF theoretical domains framework used in this study? A, to provide guidance on the cognitive, affective, social, and environmental influences on clinician behavior. B, to provide guidance on the cognitive, affective, social, and environmental influences on patient behavior. C, to identify relationships between the domains and constructs. Or D, to develop a theory to explain why DPP participants drop out. Did everyone leave? Oh, thank you. Good job. It's option B. Thank you. All right, second one. What strategies have been proposed to improve recruitment and retention in the DPP program at VCU? Use current participants as ambassadors, weekly check-ins from coaches via email, text, or phone, adopting a hybrid format, or all of the above. Yes. Excellent. Well, thank you so much. I also would like to acknowledge the contribution of two of our wonderful PharmD students, Carissa Campbell, who was awarded the AFP Grant Gateway to Research, and Ladan Karim Nihat, who is also doing a special topics with me on this topic and has been working on a manuscript, and the co-investigators on this project, Drs. Dave Dixon and Evan Sisson. And I am going to show again the information to claim credit. And I'm going to stop sharing my screen now.
Wonderful. Thank you both. Does anyone have any questions they want to just unmute and ask or drop in the chat?
I had a question. Do you have any idea why there were less men participating in your interviews?
So the Stony Point is called VCU House Stony Point Women's Center. And then the DPP, the Health Hub, I think I remember there being men in the program. I think probably Dr. Dixon can help me out here.
Yeah.
It's usually mostly women who participate.
Yeah, so this is nationally with DPP, overwhelmingly, it's women that are much more likely to participate. And that's really true for any kind of lifestyle education program or seeking healthcare in general. You know, there's a lot of data, but yeah, I think it's probably close to at least 2/3 to 3/4, somewhere in there, of participants are female. It's not unusual.
Oh. Thanks, guys. Well, if there are no questions, I can ask another one.
Sure.
Yeah, I was kind of, it's pretty interesting that lifestyle changes decrease the glucose the most, followed by metformin, right? Has anyone looked at lifestyle change with low dose metformin to see if there's a synergistic increase? I'm totally clueless about this, but when I saw that data, I thought I'd ask that question.
Sure. So the metformin group in the DPP trial did receive lifestyle education. It was just more standard, more basic, whereas the DPP, the program itself was much more involved. And so to answer your question of, you know, if we do the kind of intensive lifestyle program plus metformin, there's no like data, but certainly you would think that doing both could make a big difference. But that gets to one of the issues here is there's some pushback in the medical community of medicalizing pre-diabetes, which absolutely responds extremely well to lifestyle change and that 5% weight loss from baseline. And it's that, there's kind of two camps in the medical community. I'm all for, considering the addition of metformin for DPP participants if they're interested. I think it's something that it's reasonable to offer to them. Because I think if you combine that and you maximize your involvement with DPP, that you should certainly have, that's probably your absolute best chance to prevent diabetes. But that medicalization of something that does respond so well to lifestyle change is a big sticking point in the medical community.
Thanks, Dave.
Sure. Thanks everybody for coming. Enjoy your day.
Thank you. Good to see everyone. Happy Thanksgiving.
Thank you.